Have you ever wanted to go on a heartfelt journey in the lives of your loved ones and newfound acquaintances? Do you enjoy listening and engaging in uplifting discussions that leave you motivated and inspired to take action in your own life? This podcast is a space where we have in-depth conversations on family, health, spirituality, entrepreneurship, and well, just plain old life. I'm Jesse De Leon, and this is my passion. Join me on a walk into the fascinating narratives and meaningful conversations that shape our experiences. Welcome to The Knowing, a Life and Stories podcast. Hey everyone, let's start by introducing you to my great friend and my favorite anesthesiologist, Dr. Kevin Spence. I am so excited to have you on the show, Kevin. Kevin is a brilliant doctor, a patient teacher to his attending medical students, and an all-around deeply kind and caring human. This is The Knowing, a Life and Stories podcast. And now here is Dr. Kevin Spence. Hi, Kevin. How are you?
I'm well, burning up here in Arkansas, but glad to be here today.
Well, thank you. Thank you. We're just going to dive right into it. So, Kevin, why did you answer and choose the call to medicine? What got you involved? What made you want to go to med school?
Well, I wish I had a great story for that, Jesse. It was almost by default that I ended up in medicine. I met a good friend while I was in college, and I had done well in science, and I ended up in some science classes with his, and he was going to med school, and he said, hey, you should go to med school. So that was my thought of medicine. Fortunately, it turned out to be a great career and a great choice for me, but I wish I had a good story that it was well planned, but it wasn't, but it turned out well for me.
That's fair enough. Why anesthesia? Why that choice? Why did you choose anesthesia?
So the same, kind of a roundabout way getting here. I actually initially was boarded in internal medicine, and I trained in North Carolina for 3 years doing internal medicine. Then I did a fellowship in critical care, and through that program is where I was exposed to anesthesia. It was in the Department of Anesthesia that I did critical care training, and I got very interested in that and went for additional training in anesthesia in Little Rock, Arkansas, and I have practiced in a small community hospital for 30 years now for anesthesia. I never practiced internal medicine, but it was a great background and a good start for me, but I ended up that way, kind of a different pathway than most people do.
You enjoy it?
I do. It's a great field for me. It's a field where I can interact with patients, provide a really great service, take them from point A to point B and give them care, and it's final for me. So I really do enjoy that. It's a really great interaction, great group of people to work with daily. So it's a very enjoyable job. The hours can be bad, but overall it's a very honorable and great field to be in.
Excellent. Can you tell me and the listeners, what is anesthesia exactly?
Yeah, so basically our job is to take basically medical induction of unconsciousness and also to trick the body into not being aware of pain perception and not having reflexes under anesthesia. So we're able to use medications and technology to basically put the mind and body to sleep to allow surgical procedures without the body perceiving the pain and the procedure and having recall of that. It also provides a still surgical field for the surgeon to be able to operate. As you can imagine, if you were doing some type of neurosurgery or brain surgery, the patient would have to be totally still in order for the surgeon to be able to do that delicate surgery. So not only providing a situation for the patient and the patient's vital signs and stability, but also a still surgical field for the surgeon to be able to do his work, his or her work.
That's good to know. So what are some of the steps that you take for the patient in the beginning to get them ready for anesthesia?
So I think to answer that question, we should kind of look back, like how you get to have surgery, how you need to prepare for surgery, And then once that you arrive at the facility, kind of what happens from there. So basically, what I tell patients, you're going to get to have surgery even in an emergency situation, which is a true emergency, potentially life-threatening, where it's urgent, where it needs to be done within several hours, or it's what we call an elective surgery. So an elective surgery would be something like you need to have a knee replacement or a shoulder replacement or some type of surgery that doesn't necessarily have to be done, but for your comfort or mobility or something, you would actually electively have that done. So those types of surgeries are obviously scheduled. You've seen your surgeon, they've informed you, they're going to tell you the type of procedure, you have agreed to that, and it gets scheduled. So you're prepared for that. If it's more of an emergency or urgency, you are brought in and taken care of in those situations. So those kind of things are different. So I think today we're really going to be talking about those elective type things where you have decided or between you and your physician that you're going to need to have a surgery and that you're going to get prepared for that. So typically that means that you've had an office visit, you may have had some testing that's going to lead you to this is the best way to treat the problem that I have. So you will get some instructions from your healthcare provider, your surgeon, and they will give you specific things. So I would encourage the patients to read those instructions because they are there for a reason. And they usually work in concert with the anesthesia team for recommendations. So there may be certain medications we don't want you to take. There may be restrictions on intake by mouth that we would recommend. So those kind of things happen. Once
So Kevin,
that happens, yes.
I'm sorry. I want to stop you there for a minute. Is it normal for you to meet with the patient prior to surgery, you as an anesthesiologist? And if so, like when and why would you meet with the patient?
So there's a couple of scenarios that can happen in that as well. So even if it's an elective or an emergency, you are always going to see your anesthesia provider before. It may be very brief if it's an emergency, but definitely you're going to either see that the anesthesiologist the day of your surgery, or in some cases, you actually will have a scheduled meeting with your anesthesiologist a week or days before your surgery. If you have what we call comorbidities or several medical problems, they may actually schedule you to see a visit with me before so that we can go over all those comorbidities, make sure that you understand that we have specific instructions based on your medical history. But in general, you will always visit with them. So it's important for me to get your medical history and to discuss with you how the day is going to go and how you're going to be cared for.
And the medical history, does that have to do with medications that they're on that you need to know about as it pertains to the anesthesia and how it can affect anesthesia or the patient?
Yes, several things affect our ability to how we would care for you. So whenever we initially make contact with a patient, we basically do an interview. So we interview you and we get your medical history. We get your surgical history. We get your drug medication allergies. We want to know medications that you're taking. We want to know if you've had anesthesia before, if you've had any kind of interactions with those things. So that helps us to provide care that's safe for you. So all those things are important. So definitely one of the recommendations that I'm going to have from to tell patients preparing for surgery, if you have a medication list, that's super helpful for us to bring your medications and your medications list. If you're unsure if you should take that medicine at home before, it's best not to take it, but you can bring it with you and you can take it before your surgery if we recommended it. So definitely that. It's also very helpful if you have your medical history. Many patients come and are super organized and will have those actually typed out for us. That's super. But we're definitely going to ask you, and it's frustrating for the patient many times because I've answered these questions a million times. But for us, It's very important. We cannot be too safe. We have to have accurate information to work with. So it's just important that we go over that again and again and again to make sure that we are on the same page and we understand your history.
So Kevin, the patient can be intimidated easily by the doctor-patient relationship. What could help the doctor-patient relationship be more inclusive and where the patient feels like they can talk to you like you and I, like a normal person? Because oftentimes the patient can freeze up and not not be able to understand because there isn't that rapport. So what would you advise? What's your advice to the patient in order to build that patient-doctor rapport?
So I feel like it's a two-way street. Like, first of all, it's unfortunate. I mean, there are patients in an environment they're not used to. It's a sterile environment. It's clean. It's very abnormal to them. So it's frightening. They're about to have a procedure. So there's a lot of anxiety on their end. And then also, I think as a caregiver as well, it's different. That's something that we're so used to. We have to be sensitive that, hey, this patient doesn't understand this stuff. That we have to be on their level and make sure that they understand the questions that we're asking, that understand that they may be confused about stuff. So it is a two-way street. But what I would just tell patients, just remember that it's super important to relay information accurately, to be honest. Sometimes people will conceal stuff, and I'm just like,
Let's
no,
talk about that.
Yes, we are here. I'm not the police. I'm not, if I ask you if you're using drugs, I'm not asking to send you to jail. I'm asking for medical reasons. I'm not judging you. I'm not doing anything. All those things are super important. So just know that the posture of healthcare providers is really your best interest. We're, sometimes people may feel, I guess, that some of their privacy is invaded or whatever. In no way. We are super respectful. We're always going to ensure that you have your privacy. We're always going to be very aware of those kinds of things. But at the same time, some of the questions that we do, even your daily living, like how you live at home, do you need a cane? Do you need assistance? All those are important for us to be able to kind of tell how you function at home, and also like what you may need as you leave the hospital. So all those things are done. So again, we're all there. We are very sensitive and very respectful of our patients. That's our job. That's what we want.
Sure. So Kevin, what's another, you mentioned that patients maybe out of being nervous or scared, intimidated, that they keep or withhold information, like important information that could be possibly life-threatening. I know when we were talking earlier before the podcast, you mentioned something about like they would even maybe not even tell you that they have dentures. Why is that important? What is denture? Why does it matter that they have dentures? And why does it matter that they tell you?
So there are several kind of common things that people don't want to be disclosed, basically. So one thing is basically their dentures. So they don't want to remove them because they don't want people to see them without their dentures. And I understand that. But at the same time, when the patient goes to sleep, we do have to provide an airway for them to breathe for them. And sometimes that means placing a breathing tube down in their airway. And dentures can make that difficult. They also can get dislodged and actually obstruct the airway. So it's a safety issue. And, again, once a patient, we tell them, like, look, you can leave them to the last minute. No one's going to see you. We're going to put them right back in as soon as you're awake. None of your loved ones, none of your family members, nobody's going to see you, but it's very important. But they all the time, they'll see it. But I'll look and I go, ma'am, you have dentures in. Yes, I don't want to take them out. I'm like, I'm so sorry. You have to take those out. They have to come out. And then they'll tell me, oh, they can't come out. They're glued in. I'm like, well, they will come out. I understand that, but they have to. And, patients are understanding at that point, but it's really just takes some explaining. So they don't want to be honest about that. Sometimes they come in and they've scheduled their surgery. They've taken a day off work, but they forgot and they ate breakfast. And they don't want to tell us that. They'll say, no, they didn't have anything to eat or drink. And then at the last minute, they go, I did have some, maybe a toast. And that's important because their stomach needs to be empty in an elective case. If it's an emergency and you just ate, we can't do anything about that. But if it's scheduled, we can prepare and make sure the stomach is empty because the patients lose their protective reflexes. And that stuff can come up from their stomach, get in their airway and clog their airway. And that's called aspiration. And it literally can be lethal. So it's not dramatic. It's very life-threatening if that happens. So we try to make sure when we have the possibility to make sure your stomach is empty, it's very important. So again, we just try to explain that to patients and say, hey, this is important information. Again, they just don't want they literally sometimes will be like, I don't want to reschedule. And I'm like, we can't put you to sleep with stuff in your stomach. It was just not safe. I would be doing you a super disservice if I did anything like that. So
is there a time frame, like 5 hours, 8 hours before, like prior to the surgery?
So it does, there's definitely recommendations. And here's the issue. It's hard to give you a hard and fast rule for that. And the reason why is because some patients, because of their medical history, their stomach does not empty food in a normal, like say diabetics. They do not empty their stomach like a normal person does. There are many medications that delay emptying of your food contents. And if you're in trauma, you're in pain, you don't empty. But in general, we would like somebody to have just clear liquids no sooner than 4 hours before we put them to sleep and 6 hours for solids. Again, there are more liberal recommendations out there. And that's what I would say. Get with the facility that you're going to be having your surgery with and see what the recommendations and just follow it to the T. Like if they say, hey, you can have liquids 2 hours before, that's their protocol. That's fine. That's what they're going to be comfortable with. But there definitely will be recommendations, and they should look for those recommendations and make sure they follow them. And that not only means, hey, no breakfast, but it means no chewing gum, no peppermints, no candies or anything like that. You don't need to be sucking on lodgers because it stimulates gastric secretions and your body thinks it's eating, and it makes more gastric content. So nothing by mouth means nothing. It doesn't mean,
Wow, I didn't know that. Like chewing gum can't, it mean
no
nothing.
chewing gum, no candy, no dipping snuff, no tobacco, none of that. We also would recommend you don't smoke for 24 hours. Even if you're not quitting smoking, the carbon monoxide that it builds up, and it also makes the blood want to clot more. So it makes you more prone to blood clotting if you smoked before. So not smoking for 24 hours, you wouldn't even think would be helpful. But in fact, it is helpful if patients don't smoke for 24 hours before their procedures.
Wow, that's so good to know. I don't even know if I knew that the smoking bit and also the even chewing gum, that it could trick the what is that neurological pathways from the stomach to the brain.
Yeah, it just prepares your body for digestion, right? So it just is like, oh, if he's eating, I'm going to need to actually stimulate acid production. I'm going to need to, yeah. So
you're kind of smart.
Process. Been doing it for 30 years, so maybe that's what it is. Repetitive.
So, Kevin, what can we expect as the patient when we're waking up and, surgery's over and the anesthesia is wearing off? What are some of the what are we going to be feeling? Are we going to feel nauseous? Are we going to feel depressed? Are we going to start crying? What are some of the things? And what is common, actually?
Whenever you ask. Yeah. So I think when you just asked that question, it made me think of one thing that I think we should say in case we forget to say, because people are worried about remembering or recall during surgery, right? A lot of people I don't want to remember this. Am I going to remember this? So a couple of things they need to understand. So one thing is there's two types of anesthesia. Well, there's more than two types, but basically we can just categorize it two ways. One is called a general anesthetic, and that means the whole body goes to sleep. So it's general, like you go to sleep, the head, the chest, the belly, the legs, everything's asleep, the total body. So that's a general anesthetic. And in those cases, definitely we hope there is no recall, no nothing that patients are going to remember. Then there's another type of anesthesia that we give that is sedative anesthesia. So it's usually given through an IV. And it's almost hypnosis. So patients are very sleepy. And type of procedure that would be done like that would be if you're going to go have a colonoscopy, or you're going to have maybe some dental work, or maybe you're going to have like a skin lesion removed or cataract surgery. So they give these patients sedation. I would say 99.9% of the time, the patients have no recall of any of that. But we always tell patients, you are not fully deeply asleep. So there may be some parts of these things today, like you may remember a nurse talking, or you may remember seeing someone, but you are not going to be fully awake. But there's no guarantee that you are so deeply asleep that you're not going to maybe have some recall of something. So that's not frightening. It's normal. It's very normal that you may have some small recall, but you're not going to be awake for your procedure, listening to the surgeon talk and all that kind of thing. But
and they won't feel anything.
No, so they don't. So again, those are not deep anesthetics as a general. So sometimes my patient go, oh, I had recall. And I go, okay, what does that mean to you? And she's like, well, I had a colonoscopy and I remember that. And I go, yes, ma'am. Yes, sir. You probably did remember hearing those things. And that's not uncommon. So that wasn't a bad anesthetic. It wasn't the fault of anyone. That's just because you're not deeply fully asleep. But with a general anesthetic, honestly, in my 30 years of practice, I've never had a patient come to me and tell me, hey, I was awake. There are definitely reported cases of these things where patients said they were awake. They obviously had some recall. And, but I just want to put patients at ease. Like that is so unusual. Like that is not something we see in practice daily. And like I said, in 30 years, I've never had that. There are certain types of cases that are considered a little higher risk for recall. And one of those is heart surgery because they go on the heart-lung machine and the anesthesia medications get diluted down kind of quickly. And so there are some cases where patients may have had a small bit of recall with that. But in general, I would say that's not something for people to be concerned with, that to actually have recall of that. So back to your original question, you were saying, like, what do you expect when you wake up? So you will wake up in the operating room after the surgery, and they will make sure you're very safe. They'll make sure you're breathing, that your heart rate's normal, that your blood pressure's normal, that you're moving everything. You won't remember that. The first thing you're going to remember is recovery room, and you may not even have good recall of your recovery room visit. First thing you remember may be in the room, up in your floor, but you are awake when we finish. I would never take you out of the operating room personally without making sure your reflexes are intact, that you're following simple commands, you're breathing well, all those kinds of things. And if you aren't at that stage, once I get to recovery, I'm definitely not leaving your side until I feel you are safe, functioning well again. It's just that your cognitive ability to remember those things is not completely recovered yet. You mentioned about will you be nauseated? Unfortunately, yes, about probably 25% of patients get some nausea from anesthesia. We do a lot of things to try to prevent that, including medications, positioning, wet cloth on the head, all this kind of stuff. But despite that, still patients will get nauseated. Certain types of procedures are more prone to the nausea vomiting as well. Some people are super sensitive to narcotics. Some people are super sensitive to anesthesia gas. So nausea is one of them. Usually patients are sedated and groggy when they first wake up. They may have a very dry mouth from the medications. They may have blurred vision because we put lubrication in the patient's eyes. And so when they wake up, they can't see well. Because their eyes have still got the lubrication in. So it's a little, their eyes are a little cloudy. And again, we just reorient the patient over and over. Hey, you're in recovery room. You're doing well. Your surgery's over.
That's good to know.
Yes. It just, yeah. Yeah.
That's great. And what about I know when we were talking earlier, you mentioned something about the dignity of the patient. Can you speak on that?
Yeah. So I think a lot of patients, especially we get younger adolescent people in there and they're super private. And I usually try to console them beforehand and say, hey, it's very cold back there. You're going to have on a gown. You're also going to have covers on. Those covers are going to stay on you. You are not going to be uncovered. We do need to place monitors on you, and that may mean that we have to put some little sticky pads around your chest area or on your side, a blood pressure cuff on your arm, a little oxygen probe on you. But we try to keep you covered while there. Of course, if they're having surgery, the surgical side has to be exposed after that. But, we definitely respect that. No one ever says, I should say never, but it is unprofessional if anyone ever says anything about a patient. We just don't do that. We don't talk at that. It is totally there for business, totally respectful situation that and professional when you're in the operating room with these patients.
That's great. That's really good to know because I'm pretty shy about modest. So I want to know that people aren't looking and talking about me.
Yeah, no, I mean, it is a concern. I mean, it's kind of like the elephant in the room. Nobody wants to talk about it. And of course, just like everything in the world, like you see these situations where people have said, but I would like to defend our profession, not just anesthesia, but healthcare professionals. We are professionals, and that's not acceptable. So, of course, people can go rogue and do something, but it is not professional. We take that very serious. We understand these patients are in a vulnerable situation. We are there to take care of them, to take them from point A to point B. And that's part of that, is to making sure they feel safe, cared for, and comfortable.
That's great. Great to know. I want to move on to does anesthesia affect demographics in different ways? age, age versus young and old? And also, does the sex matter, male, female? Does anesthesia work differently or have a different effect on those demographics?
Boy, so definitely the answer to that question is easy for age, because for sure extremes of age, either young or old. So definitely people that are older. A couple of things. So I just have a silly analogy, but when you're younger, kids don't tend to like a lot of different foods, because sweet is really sweet, sour is really sour, because all their nerves are so young and fresh, they can taste really well. And as we get older, we like, oh, I didn't used to like that. Well, you start to like it now because you can't taste as well, probably. So sour doesn't seem so sour, or salty doesn't seem so salty all of a sudden. So the same thing as we age, the nerves don't tend to be, the pain nerves are not as good. So if you're young and you're 14 or 15, it hurts. And when you become 80, your nerves aren't functioning as well. And so they tolerate pain much better. So you'll be surprised, like I give an anesthetic afterwards, I may give a young person 10 milligrams of morphine, and I may give an elderly person 1 milligram of morphine, because they just don't hurt. You just wake up and be like, hey, are you hurting? They're like, no, not hurting. They got a big incision on their stomach. You're like, wow, okay, good. So they don't require as much pain medication. So that's one thing, is we know the amount of anesthesia. So that's from a pain perspective, but also from a cardiovascular or blood pressure, heart rate kind of perspective as well. Like, these patients don't tolerate, like, I can't give them the same dose as I would give a healthy person. So if I give a 20-year-old a certain dose of a medication, I cannot administer that to an 80-year-old person. Their blood pressure will totally plummet. Their heart rate may go flatline. I mean, so definitely we have to dose appropriate for age. And the way that we dose our medications really is based on a body weight and also age. And also we do what's called titrating. So I only give a small amount. I see what their response is. I give more if I need it. I can't take it away. So we usually just like dose it a little bit. It's almost like you're cooking and you add salt, you taste it, oh, I need to add some more salt. So that's kind of the way we do with our anesthetic. And we're basing it based on their body weight, but also the response that they have. If their heart rate's going up or their blood pressure's going up. We Kevin, titrate those things in. So
could there be memory loss or fogginess in the days to follow anesthesia?
Yeah, that's a good question, and one that's difficult to really tease out, because there's so many factors that could really affect that. But we definitely know it is a reality. And it's very interesting, because when I first started out, I would have patients tell me all the time, hey, when I had so-and-so, I felt like I couldn't remember. I've lost kind of my memory ability. And it would be, and I took it to heart, but it wasn't in the literature yet. But I was like, there's something to this, because my people tell me this. And I'm like, it's not just like, so in fact, there's been, in the recent years, more people have what they call cognitive dysfunction. And it is more common in elderly, and it's also more common who are susceptible to that. If you already have dementia or early dementia, or you already have Alzheimer's or something like that, or you've had a stroke before, or you have cognitive dysfunction before you ever come to surgery, those patients are at more risk. Fortunately, most patients recover from that. But in the elderly, maybe up to 30% may actually have some cognitive dysfunction after an anesthetic. There's been some studies trying to look at like the longevity of the surgery, the types of surgery, those kinds of things, which it would put you more at risk. But I don't know. But there's really nothing to do that we know of to prevent it. Intuitively, we try to minimize the dose and the exposure to anesthesia time.
Right.
And it seems to make sense. But we don't have any studies to say, hey, that's helping.
Well, thank you for answering that question. How has anesthesia changed in the last 30 years, Kevin? You've mentioned several times you've been in anesthesia for 30 years. How has it changed, if any?
Yeah, so, interesting. I think you and I talked a little bit about this before, and I'm sure it's changed more than I realized. But I've really practiced very similar to what I did. We've had some new medications come out that are faster metabolized, less side effects. We have a little bit of technology that's come out that's definitely helped us take. I always make it akin to Wheel of Fortune when you're trying to guess a puzzle. when you're taking care of a patient. Like there's some things you just know, sometimes you got to buy a valve. So some of those technologies have really helped us get more information and data points to help take care of patients. But I would say in general, just the big things that have come out that made differences would probably be pharmacology with pharmacological agents like drugs that are quicker acting, quick onset, quick offset, less side effects, less nausea, vomiting, maybe less cognitive dysfunction, that kind of stuff. And some data point information that's changed. But it hasn't changed that much. I would also say anesthesia is super safe, like it is very safe. First of all, you have a human that's monitoring and taking care of you, plus you have technology that's monitoring and helping take care of you. So we will monitor a patient's body temperature. We measure their urine output. We measure their carbon dioxide level. We measure their oxygen level. We measure their heart rate. We measure their blood pressure. We're constantly vigilant, looking physically at the patient, making sure they're positioned well, that their arm is not in a situation where it could get pinched or hurt, that they can't feel it. We're making sure their eyes are protected. We're making sure the surgeon's not leaning on their face and damaging their eyes or anything like that. So there's a lot of safety and a lot of forethought that goes into taking the patient, because the patient can't take care of themselves. They can't advocate for anything. They can't feel. They're not going to move. They're not going to withdraw from pain. So all those things have to be taken into account.
You are their warrior for sure. Kevin, I'm going to sort of close the conversation with you with a fun fact. What has been your favorite, if any, treat or gift that a patient has ever given you? And you have 30 seconds to answer that because we're going to have to end the interview.
Yeah. I would just say for me, honestly, like the gratitude that I get for interacting with patients, like it's not something somebody intentionally gives me, but I love visiting with patients I love hearing their stories. I love hearing what's gone on in their life, the experiences they've had, and interacting. I share photos with my patients. I look at their photos. So that's a joy for me. So that would be it. I've definitely had patients Yeah, but I've had patients bring me preserves. They bring me cookies. They bring me stuff. So all those things are sweet and kind. But yeah, just the interaction with the patients is just awesome. That's a great part of my job.
So remember, everyone, bring your brag book and show Dr. Spence your photos of your children and family when you come in to visit. That'll actually help build a rapport and touch his heart. Kevin, it is always such a pleasure to talk with you. Again, I mentioned earlier, you are one of the kindest people and genuinely sincere, and you love what you do and you're so passionate about it. And I always enjoy talking with you about your passion. And so on another time when we talk, we're going to talk more about your passion and how it pertains to anesthesia and your patients. Thank you again so much for being here. You definitely, I want you back on the show and as a recurring guest. Once again, thank you so much. And I look forward to talking to you again.